You know, in the Middle Ages,
I told you guys. I warned you.
The penalty for heresy, is this still working? Good.
You're
the
good.
penalty for heresy could be extremely severe, particularly for recalcitrant heretics, those who, despite having been counseled, would refuse to recognize the error of their ways. And I am praying.
I told you he's going to walk around.
And I'm using the word praying deliberately, that in this more enlightened era, you will be more merciful and more reasonable. And I will not. I will be able to get out of here alive and not be burned at the stake. But yes.
You want to thump on?
Praise Jesus.
You want to thump on that?
So why do I do that? There are a number of reasons, and these are just a few. And I, too, tried to keep this short. Each of these could easily be an essay unto itself. I'll start, and Renee accused me of defending doctors. I take no greater pride in anything else I've ever accomplished.
It wasn't an accusation?
It was an accusation, sir. We start with the concept of the standard of care. Oceans of ink have been spilled on this topic. Avogadro's number of electrons have been expended explaining this topic, and yet is still not understood. The standard of care, the yardstick by which the conduct of healthcare professionals is measured, is a matter of history. It is a matter of the habit, the practice within a particular specialty or a particular profession. And in principle, under the law, if the defendant, clinician, has done X, where X is what everybody else in the field does under similar circumstances, then no matter how grim the outcome might be, he has complied with the standard of care, there is no case, and there should be a defense judgment. That's the standard of care. The problem, or a problem, with clinical practice guidelines, with best practices and the like, is that they generally are written with the goal of improving the quality of care. Now, how could anybody oppose that? Even someone as cruel and heartless as a malpractice defense lawyer. The reason that I'm worried about that is because the law, for all of its limitations, recognizes that none of us is perfect. Otherwise, I would be giving this presentation not from here, but from my jail cell. You are not expected to be perfect. You are not expected to live up to the theoretical ideal that some group of graybeards, in their wisdom, sitting around a virtual or real table, decided was the ideal way to care for patients. Instead, you're supposed to be measured by what other people in your field, standing in your shoes, would do under similar circumstances. I guarantee that the plaintiff's bar will not hesitate in the slightest to employ guidelines crafted by really smart people, highly educated, highly trained, highly experienced, very often among the finest in their fields, as weaponry against old Doc Smith down on the corner. They will use it 6 ways to Sunday, and they will use it and cause harm, which will not only harm him, but ultimately the patient, and that means all of us. Fundamentally, we don't even have consensus on what the meaning of evidence-based is. If you poll providers, and this has been demonstrated empirically, if you poll providers, they will assume and they will tell you in their answers that it means data based on randomized clinical trials, the so-called gold standard of scientific medicine. But in reality, if you examine the guidelines, what you discover is that very often they reflect a consensus of wise people, learned people, with or without the benefit of randomized clinical trials, or for that matter, any other empirical data. Sometimes the data just aren't there to answer the question, and when they aren't, the guideline issues nevertheless, very often without any clear indication of the strength of the opinion that it is based upon or the quality of the data that inform that opinion. In the event that there is a trial against some poor soul who's accused of something, a big question will be admissibility of these guidelines under the hearsay rule. A hearsay means, and it's a complicated subject, but essentially it's an out-of-court statement offered for its truth. And so plaintiff's counsel will attempt to hit you over the head with whatever your specialty had to say about subject X, where subject X is the topic framed by the care that is being criticized. Defense counsel will more than likely attempt to keep it out of evidence, and there'll be a fight over that. The judge will determine it based upon state law and upon the judge's own predilections. But it's very hard to know in advance whether the guidelines will be admitted or not. If they're not, then we don't have to worry about them from a lawyer's point of view. But if they are, then we're going to go through chapter and verse, and I will tell you that there are more than 2,700 guidelines currently published by august, respected organizations available for the plaintiff's bar to pick from. And that data are old. That number is several years old, and by now, given how frequently they proliferate, they're like rabbits, there are probably many more. Now, Jay made the point that there are criteria for judging whether guidelines are good or bad, and there absolutely are. In fact, as he points out, there is more than one such source. I chose the Institute of Medicine as a takeoff point just because most people respect the IOM and because it's made up of really smart people who do really smart things. They have a list of about 8 different criteria by which one can judge the quality of a given guideline. The data are convincing and persuasive and consistent that rarely, if ever, are clinical practice guidelines articulated by the finest minds in any given specialty, rarely, if ever, do they meet the criteria of the IOM. And there are about 8 of them. I didn't memorize them, and I did try to keep this short. But for example, it's important from the IOM's point of view that we indicate who provided financial support for the creation of these guidelines. I'll get to that in a minute. It's important to the IOM that there be some evidence of the strength of the data upon which the guidelines were founded. If you examine them, rarely does that occur. IOM says there should be a lot of diversity among those who articulate these guidelines. For example, there should be patient representation among the groups that do these things. There should be data scientists among those who speak to these issues. There should even be economists, according to IOM. Now, that in itself raises a bunch of issues. We're talking, I assume, about the quality of care. We're talking about how doctors and other clinicians ought to care for patients. To what extent does economics have a voice in that question? And I suggest to you that society's ambivalence, meaning America's ambivalence about that very question, has a tendency to influence the content and the quality of the guidelines that are generated. The IOM tests are hardly ever met. Moreover, guidelines come from a whole multitude of sources. If tomorrow morning 3 of you randomly decided we want to write new guidelines on the management of kidney stones, there is not a thing in the world that can prevent you from doing that. And if you get it published, somebody might believe it, and you might have your set of guidelines. The problem is that 37 other people have done the same thing, and they've reached different conclusions. Let me give you a very good example. Coumadin is a very valuable drug. It's an anticoagulant, a blood thinner, and for some people it has avoided strokes, it has saved lives. But it is also a very dangerous drug and very hard to use well. Now, as a result of the growth of science and technology, we now have a method to ascertain in advance, to a substantial extent, the risk to which I am exposed if my doctor recommends that I take Coumadin. Why? Because the doctor can now look at my genome. It turns out that a great deal of the risk is a function of genetics. So by knowing what my genetic makeup is, my doctor can make a better judgment about whether my risk for taking Coumadin outweighs the benefit of my not taking it. Now, there's an august group of scientists and scholars from around the world. These are renowned people, first-class folks, who have a very long name that I won't try to provide for you exactly. It's the CPIC. It is something like the Council of Pharmacogenetics Initiative Consortium or some such. Very smart people, recognized around the world. They have made it very clear that their view is that before Dr. X starts me or anybody on Coumadin, it's his obligation to find out what my genes say about my risk. And if that risk is unacceptable, don't write for the drug. On the other hand, the American College of Physicians, the specialty society of that group of specialists in this country who devote their lives to the care of adults with diseases of vital organs, has said quite clearly there is no reason to do that test in advance of making the decision. Go ahead and give the Coumadin if that's your best judgment. Now, if I were in practice and I had this wise group of scholars on the one hand telling me test, I have another group of scholars on the other hand telling me not to test, what exactly am I supposed to do? And how am I benefited by having this conflicting information as I try to make this difficult decision? And mind you, I do not have 6 months to think about it. I can't go to the library every time I have to make a judgment about what to write for. I've got to make that judgment, and I've got to make it fairly promptly. Otherwise, it becomes academic. Then 2, some of these guidelines are provided by health insurers, the folks who pay the tab. Now, I'm not knocking health insurers in the least. We all depend upon them. But if I were running a health insurance company and I was considering what might be the best way to give guidance to doctors and others who care for my insureds, would my judgment, would my opinions be based entirely upon whatever the best science is and whatever is the best clinical care? Maybe. But then again, would it be so unreasonable for somebody like me to ask the question, is it possible that your need to generate income could have some potential impact, perhaps, upon the way in which you approach this subject? Or consider it, perhaps, from another point of view. There are companies that make pharmaceutical products and medical devices, and I don't knock them either. We are all indebted to them for what they do and what they provide to us. But like the insurers, they are profit-making, or at least profit-seeking organizations. Well, guess who sponsors these guidelines? Well, lots of people. But among them are companies in the biomedical sciences. And it's a good thing, in a sense, because without that money, there probably wouldn't be much support, at least in some instances. Would it be so unreasonable to ask if it's at least remotely possible that the fact that pharmaceutical money or medical device money supports the promulgation of guidelines has some impact, or at least some potential for impact, upon the content of those guidelines? Rene has already agreed that obsolescence is a problem. What he didn't point out to you is the data suggest that between the day some smart scientist makes some brilliant observation that could change the course of medical history and the management of problem X, and the day that that discovery finds its way into a guideline, is 17 years. Long enough, almost, in contemplation of law, to transform a newborn baby into an adult.
Just tell them. Just tell them.
Now, as a father of three, I'm here to tell you that 18 years is a legal fiction, but nevertheless, that's the inflexibility. Those who write these things have a tendency to invoke the Old Testament and to say, thou shalt, or thou shalt not, which is very hard for the defense lawyer to deal with. There's not but so much running room when the language is phrased in that way. Vagueness or level of detail. Some of these guidelines are written with a density and a turgor that one could be excused perhaps for wondering whether the source of this purple prose that's largely impenetrable was not a bunch of scientists and doctors, but rather a group of lawyers.
Come on.
On the other hand, some of them are so vague as to be largely meaningless. And what good is a meaningless guideline to me as a clinician? Now, I'm realistic enough to know that the train has left the station. Those 2,700 guidelines are not going to go away. Indeed, they're going to multiply in the dark. We're going to have more of them, not fewer. So if you must write these things, and I suppose some of you think you must, indeed, 90% of you think you must, my best advice, this is the best thought I've been able to come up with on this very topic, is specifically state in your guidelines that the purpose of the guidelines is to improve the quality of care. Why? Because that gives your friendly local defense counsel an opportunity to argue, Judge, these guidelines are by their own terms intended to improve the quality of care. We're not here to improve the quality of care. We're here to determine whether, on this occasion, Dr. X did or did not comply with the standard of care. Did he or did he not do what his colleagues would do in similar circumstances? Since the guidelines are geared towards a different goal, they are irrelevant, they are admissible, and we should no longer discuss that subject. And I think that's not a half-bad argument. The other ones are from other folks. I don't claim any originality with those. Most of them are fairly clear. Some of them, I think, have already been made. It would still be my view that if you are not a fan of hangings, and I'm not a fan of hangings, if you're not a fan of hangings, stop manufacturing so damn much rope. But if we're going to manufacture the rope, at least consider ways to make it somewhat less lethal so that some of you will be able to walk out of court without having got hurt. Thank you.